All right, time to dive into this mountain of research on breast cancer screening. We're going deep on mammography today. The different types, when it's most effective, even some potential downsides.
Definitely a lot to cover.
Yeah. You've got patients asking about when to start, how often to get screened. It can feel overwhelming trying to keep up with all the latest evidence.
It really can. And these decisions have a real impact. So that's why we're here, I guess. To break it all down, give you the confidence to have those conversations with your patients.
Exactly. So let's start with, I guess, the basics. Mammography, it's still the go-to for breast cancer screening.
It is. For average risk women, at least, every major organization, you've got the U.S. Preventive Services Task Force, the American Cancer Society,
Yeah.
they all point to mammography. And for good reason.
Yeah.
Randomized trials have shown it can reduce breast cancer deaths.
Okay, yeah. That's powerful evidence.
It is.
But I know there's been some debate about how relevant those older trials are now, with all the advancements in treatment we have.
Yeah, that's a key point. Most of those trials happened before we had many of today's targeted therapies. So while mammography still catches cancers early, the impact on actually saving lives, well, it might be less dramatic now than those initial studies suggested.
Interesting. So should we be less confident in mammography's effectiveness now?
Not necessarily. We just have to be realistic about the limitations of the data. Thankfully, newer observational studies, ones looking at more modern technology like digital mammography, well, they do suggest screening is still making a difference.
Okay, good. That's good to hear. So let's talk about the different types of mammography. I feel like film mammography is practically a museum piece now.
Pretty much, yeah. Digital is the standard these days. Overall, the accuracy is similar, but digital has some clear advantages for certain women. We're talking women under 50, pre or perimenopausal, and women with dense breasts.
Dense breasts. That seems to come up a lot in these discussions. Why is that such a key factor?
It's all about how clearly we can see potential cancers on the mammogram. Dense breast tissue shows up white on the image, and so do tumors.
So it's like trying to spot a snowball in a blizzard.
Exactly. And digital mammography does a better job of seeing through that density compared to film.
So for those women, digital mammography is more likely to find cancers that might have been missed with film, I mean.
Potentially, yeah.
Yeah.
But there's a trade-off. Digital also tends to have more false positives in these groups, more callbacks, and potentially unnecessary biopsies.
That's a tough balance. Finding more cancers, but also causing more anxiety and extra procedures.
Yeah, it is. It's something to keep in mind when we're tailoring screening recommendations for individual patients.
For sure. So we've got digital mammography, which is good but not perfect, especially for those with dense breasts. Now, what about this 3D mammography I keep hearing about? Is it all it's cracked up to be?
It's showing some real promise. 3D mammography, or tomosynthesis, takes multiple images from different angles, almost like a CT scan for the breasts. This lets us see through the tissue more effectively, like flipping through pages in a book to spot a tiny detail.
So we're getting a more complete picture with 3D mammography.
Exactly. And the trials are bearing that out. They're showing modest but significant improvements in both cancer detection rates and a reduction in false positives.
Wait, so we're finding more cancers and having fewer false alarms? That sounds almost too good to be true.
It's definitely a step forward, particularly for women with those very dense breasts. But we still need more long-term data to see how that translates into lives saved. And it's not universally accessible yet, as we know.
Right. Cost and insurance coverage, always a hurdle.
Yeah.
Something else I've always wondered about 3D mammography is the radiation exposure. Isn't it much higher than with regular mammography, I mean?
That was a concern early on, yeah. Initially, they were doing both 2D and 3D images,
Yeah.
which effectively doubled the radiation dose.
Not ideal. So is that still the case?
No, thankfully, technology has advanced. Now, with something called synthetic 2D, they can create those 2D images from the 3D dataset.
So two for the price of one radiation-wise.
Exactly. The radiation dose is comparable to standard digital mammography now.
That's reassuring. Okay, before we move on from mammography entirely, what about MRI? Where does that fit into the screening picture?
MRI is a powerful tool, but it's not for everyone. It's far more sensitive than mammography, meaning it can pick up even tiny abnormalities.
Okay.
But it's also less specific.
Less specific, meaning more false positives, more biopsies for things that turn out to be benign.
Precisely. So for average risk women, the downsides outweigh the benefits. We don't have data showing it saves lives in that group, and the potential for anxiety and unnecessary procedures is high.
So MRI is reserved for higher risk patients then?
Yes. Think women with BRCA mutations, strong family history, other factors that put them at increased risk. In those cases, the benefit of finding even the smallest cancers early, well, that can outweigh the downsides.
Makes sense. But what about women with dense breasts? We know mammography can be less effective for them. Is there a role for MRI in that group?
There have been studies looking at that. It's a hot topic right now. One key study found that MRI did find more cancers in high-risk women than mammography alone. But, and there's always a but,
I'm sensing a butt coming. What is it?
the study wasn't designed to see if those extra cancers found by MRI actually led to lives saved. And that's the crucial question.
So we're still waiting for more data before recommending MRI solely based on breast density.
Exactly. There's a lot of research still underway.
All right, so we've covered the high-tech stuff. Now let's talk about something a bit more old school. Palpation. I remember learning about the clinical breast exam in med school, but it feels like it's gotten less attention lately.
It's true. With all the focus on imaging, palpation can feel almost forgotten. But a well-performed clinical breast exam can still add value. The problem is, it's difficult to standardize.
So the effectiveness depends a lot on the individual clinician's skill.
It does, yeah. There's a lot of variability in technique and how thoroughly it's done. In real-world settings, the sensitivity of palpation alone is probably quite low.
And what about breast self-exams? I get asked about those all the time.
Here's the thing with breast self-exams. The studies haven't shown a benefit for early detection or survival, I mean. And in fact, they've been linked to more biopsies for benign disease, which just adds to the stress and healthcare costs.
Wow, so potentially doing more harm than good. That's something I'll definitely be discussing with my patients.
It's a conversation worth having. We need to make sure our patients have the most accurate information, even if it means challenging some long-held beliefs.
Absolutely. Okay, we've covered a lot of ground here, but there's one big piece of the puzzle we haven't discussed yet. The potential downsides of screening. False positives, overdiagnosis. These are real concerns.
They are. We can't have a truly balanced conversation about screening without acknowledging those potential harms. And that's exactly what we'll dive into next. Welcome back. So we've been unpacking this whole world of breast cancer screening, talking about the different modalities, the pros and cons, all that. Now let's tackle something I know GPs deal with all the time, navigating the various guidelines out there.
Oh, yeah.
Right.
That's a real headache sometimes.
It is.
I mean, you've got the USPSTF, you've got the American Cancer Society, the American College of Radiology. They don't always agree, do they?
They don't, and it can be really confusing for both doctors and patients. So let's break down some of the key recommendations, and importantly, I think the rationale behind those differences.
Okay, sounds good.
Uh,
Who should we start with?
Let's go with the U.S. Preventive Services Task Force.
Okay.
The USPSTF, since they're often considered, the gold standard for evidence-based recommendations.
Right, the data-driven folks. What do they say about when to start screening?
Well, their latest recommendations, which were updated in 2024, suggest starting mammograms at age 40 for women at average risk.
Okay, 40. And how
Yeah.
often are we talking here? Yearly mammograms.
Actually, they recommend every other year.
Oh, okay.
So biennial screening for women aged 40 to 74.
Interesting. So less frequent screening than some other groups recommend. I'm guessing that's where the weighing of benefits and harms comes into play.
Exactly. The USPSTF acknowledges that more frequent screening might catch a few more cancers, but they're also really focused on minimizing those potential downsides. The false positives, overdiagnosis, all the things we were talking about earlier.
Right, makes sense. Now, are there any organizations that recommend starting screening even earlier than 40?
Yes, the American Cancer Society is one, the ACS. They suggest women have the option to start annual mammography at 40, but should definitely begin no later than 45.
Okay, so a bit more aggressive in their approach. Why the difference? Are they not as concerned about the harms?
It's not that they're dismissive of the harms, but they place a higher value on the potential benefits of early detection. They argue that finding cancers earlier can mean less extensive treatment and better outcomes overall.
I see. So it's a matter of emphasis.
Yeah.
The USPSTF putting more weight on avoiding potential harm, and the ACS emphasizing catching those cancers as early as possible.
Yeah, that's a good way to put it. And of course, individual patient factors like family history can also shift that balance as well.
Right. We're not just blindly following guidelines. We're using them to inform those individual conversations with our patients.
Exactly. Now, before we move on, there's one more organization I want to mention, the American College of Radiology, or ACR. They recommend annual mammograms starting at 40 for average risk women.
Okay, so they line up with the ACS on the starting age, but they're pro-annual screening, not every other year. This is getting complicated.
Yeah.
How do we as GPs make sense of all these different recommendations?
Well, it really boils down to how each organization weighs the evidence and how much emphasis they place on various studies. The USPSTF, they really lean on randomized controlled trials, which are the gold standard, but often don't capture all the nuances of real-world practice.
Yeah.
The ACS and ACR give more weight to observational studies and expert consensus, which can sometimes lead to more aggressive recommendations.
So it's not about one set of guidelines being right and the others wrong. It's about understanding the reasoning behind those differences
Yeah.
and then using our judgment.
Exactly. And that's where those conversations with patients become so important. We can explain the different viewpoints, discuss their individual risk factors, and really work together to make a decision that feels right for them.
Shared decision-making in action.
Yes.
Okay, so we've covered when to start screening. What about stopping? Is there like a magic age when we say, all right, you're good, no more mammograms?
I wish it were that simple. Unfortunately, there's no consensus on a specific stopping age. Some organizations, like the ACS, suggest continuing as long as a woman is in good health and has a life expectancy of at least 10 years. The USPSTF doesn't have a hard stop, but their recommendations do apply to women up to age 74.
So for women over 75, it becomes even more individualized.
Absolutely. We have to consider things like their overall health, any other medical conditions, their personal preferences, and really have that honest conversation about the potential benefits and harms at that stage in life.
Right, because even if screening finds something, the treatment might be more risky or burdensome than the cancer itself at that point.
Exactly. It's about quality of life, not just quantity.
Okay, so we've covered when to start, when to stop. But there's one more scenario I want to dig into. What happens when a mammogram shows something suspicious? The dreaded callback.
Ugh, those are never fun, but they're a crucial part of the process. Remember, the whole goal of screening is to find these cancers early, when they're most treatable. So if we see something that doesn't look quite right, well, we have to investigate further.
Right, better safe than sorry. So what happens after a callback? Walk me through the steps.
Usually, the first step is additional imaging. This might mean getting more views of the same area with mammography or doing a targeted ultrasound. Sometimes an MRI might be used as well, especially if there's, a strong suspicion of cancer based on that initial mammogram, or if the woman has dense breasts.
And if those additional images still look concerning?
Then we have to consider a biopsy. That's the only way to definitively determine if those suspicious cells are cancerous or benign.
I know it's important to reassure patients that a callback doesn't automatically equal cancer.
Oh, absolutely. The vast majority of callbacks turn out to be benign findings, but even then, going through those extra tests and waiting for results, it can be incredibly anxiety-provoking.
Yeah, no doubt about it. It's a lot to process, both physically and emotionally.
That's why clear communication and empathy are so important throughout the process.
Right.
We need to explain what's happening every step of the way, answer their questions honestly, acknowledge their concerns. Sometimes just listening and validating their feelings can make a world of difference.
Absolutely. It's about treating the whole person, not just the mammogram.
Well said. And that brings us to our next segment where we'll step away from the guidelines a bit and dive into some real world case studies because that's where the rubber really meets the road, isn't it? Seeing how these concepts actually play out in the lives of our patients.
Okay, let's put all this knowledge into practice. I'm ready to tackle some real-world cases, see how we can apply these screening guidelines and all the concepts we've been talking about.
Perfect. I've got a few scenarios that I think will really highlight those dilemmas and nuances we face as GPs every day.
All right, hit me with your first case.
Okay, so picture this. A 43-year-old woman comes in for her annual checkup. She's healthy, no family history of breast cancer, nothing concerning on exam. But she's been, hearing a lot about breast cancer in the news lately, and it's got her feeling anxious. She asks if she should start getting mammograms now.
Ah, the worried It's a common scenario.
It is.
She's younger than the age recommended by the USPSTF for routine screening, so how do we navigate this?
Well, this is where those individualized conversations we keep talking about, they become really important. First, you validate her anxiety.
Yeah.
It's completely understandable to be concerned about breast cancer, especially with all the media attention it gets.
Yeah, for sure. So we acknowledge your feelings, but then what? Do we just sort of lay out the different guidelines and let her decide?
It's a little more nuanced than that. I mean, we can certainly walk her through the key recommendations, the
Yeah.
USPSTF suggesting start at 40, the ACS offering the option to begin earlier, but the key is to really frame those guidelines within the context of her personal risk.
Right. And in this case, her risk factors are pretty low, no family history, otherwise healthy. So would you lean towards recommending that she wait until 40 to start routine screening?
I might, but again, it depends on the conversation, you know? It's about understanding her concerns and her values. If she's truly anxious and feels strongly about starting earlier, well, I wouldn't necessarily discourage it. We can discuss the potential downsides of earlier screening, the higher likelihood of false positives, the possibility of overdiagnosis, and all those unnecessary interventions. But ultimately, it's about finding a path that feels right for her.
Yeah. Shared decision making at its best. Okay, next case. Bring it on.
Okay, all right. How about this? A 55-year-old woman who's been like religiously getting annual mammograms since she was 40. Her mammograms have always been normal, but this year she comes in asking about 3D mammography. She's heard, it's better, especially for women with dense breasts.
This is a hot topic. 3D mammography is getting a lot of attention. So what do we tell her?
I think it's a great opportunity to have a really informative discussion. We can explain that the research on 3D mammography or tomosynthesis is promising, particularly for women with dense breasts. We can talk about those potential benefits, higher cancer detection rates, fewer false
But
positives.
we also have to be upfront about the limitations too, right?
Absolutely. We still don't have like long-term data showing that 3D mammography actually saves lives, and it can be, more expensive and not always covered by insurance, which is a real barrier for a lot of women.
Yeah, right. We have to be mindful of those practical considerations. So would you recommend 3D mammography for this patient?
If she has dense breasts, I think it's a reasonable option to discuss. We can explain the evidence, the pros and cons, and let her decide what feels right. Again, it goes back to that shared decision-making model.
Okay. Last case.
Hmm.
I'm ready for a tough one.
All right, here we go. A 68-year-old woman comes in for a follow-up after a mammogram showed a small cluster of calcifications. The radiologist recommends additional imaging and possibly a biopsy, but she is terrified. She tells you she doesn't want any more tests, she doesn't want treatment, she's had a good life, and she's, ready to let nature take its course.
Wow, this is where it gets really challenging. We're talking about more than guidelines and statistics now. We're talking about, respecting her wishes, her values.
Absolutely. This is where our skills as compassionate listeners and communicators are truly tested. We have to acknowledge her fear, her right to make her own choices about her body and her health care.
But we also have a responsibility to, make sure she's making an informed decision, right?
Of course. We can, gently explain that those calcifications might be nothing to worry about, but there's also a chance they could be cancerous. And that early treatment, if it's needed, often leads to the best outcomes.
But ultimately, the decision rests with her.
It does, and if she has made a clear and informed decision to decline further testing or treatment, we have to respect that, even if it's difficult. We can offer support, connect her with resources, but we can't force her down a path she doesn't want to take.
Yeah. This case really highlights that, human side of medicine. It's a powerful reminder that we're not just dealing with diseases, we're caring for people, you know, people with their own stories, their own fears, and their own hopes.
Couldn't have said it better myself. And I think these cases demonstrate just how complex and nuanced this whole area of breast cancer screening is. There's no one-size-fits-all approach, no easy answers.
Absolutely. It's about listening to our patients, understanding their individual needs, and working together to find the best path forward.
Well said. And hopefully this deep dive has given you the knowledge and confidence to navigate those conversations with, even greater skill and compassion.
I think it has. And remember, this is just the beginning. There's
Mhm.
always more to learn, more research coming out, more ways to refine our approach to breast cancer screening. So keep those critical thinking skills sharp and don't hesitate to uh, dive deeper into the evidence whenever a question arises.
Because that's what being a good doctor is all about, isn't it? Lifelong learning, staying curious, and always striving to provide the best possible care for our patients.
Couldn't agree more. Thanks for joining us for this deep dive into the world of breast cancer screening.